So I guess we'll just continue onwards. You can see here from, let me just back it up a little bit with the suturing. There's two different ways to, or there's many ways to grab the suture. I think this is a good way here, is you dangle it from the suture itself. I try not to handle the needle too much, because when you do that, you tend to bend it or you tend to dull the tip. But if you just grasp it, if you grasp the suture just about a centimeter from the end of the needle, if it's too far, then it's going to dance around and you're not going to be able to control it. But if you got it about a centimeter, and then you allow the needle to sit on the cornea with surface tension, then you can make it dance like a puppet. You can flip it around. You can flip it so that you can grab it right-handed, or you can spin it the other way so you can grab it left-handed. So some people will call it forehand or backhand, but I think the more correct terminology is right-handed or left-handed. So if the tip is pointed towards you, then that's considered right-handed. If the tip is pointed away from you, then that's left-handed, because I guess a left-handed surgeon, yeah, how did that come to evolve? I don't know, but that's as far as I know, that's the correct way to say it, is right-handed and left-handed. But the nurses might not understand that terminology, and sometimes just quicker to get it yourself. Okay, so once you've got the needle, you don't hold it on the rounded part of the suture. Go down about 1/3 where the needle starts to flatten out. And these Kohan micro minis are very good for that purpose, because they're a little bit wider at the tooth, so it will grasp that flat part of the suture or part of the needle and allows you better control of it. If you're holding it on the round part, then the needle will have a tendency to torque. And when you're putting in these side sutures, what I suggest is shift your chair slightly to the left, and it will give you a better range. So you shift your chair to the left and then pick up the tissue. Don't grab it full thickness. Try never to grab the tissue full thickness, whether you're doing it with your first suture with the 2-prong Pollux or with the 0.12s. Grasp it about 50% thickness if you can. And then once you've grasped it, then just turn it a little bit like this. And what that does, and don't lift it up. Keep the tissue down in the plane that you're sewing in. So lift the edge up, and it sort of fans it open. I have to get more props here. It sort of fans it open like this. So, you can actually see the thickness of the edge, and then you want to pass the needle so that it comes out just anterior to Decime's membrane if you can. Oh, I remember the name of that surgeon in New York, Troutman, Richard Troutman, Dick Troutman. And the reason I'm reminded of him at this point is because he advocated full thickness suturing. And what's the advantage of that? I think he proposed that you got quicker wound healing, and you had better wound apposition, better vertical wound apposition. If you don't get good vertical wound apposition, that will create astigmatism. But even the other thing that happens is if your wound is like this, with one edge up, then all of this stromal tissue is exposed to what becomes the subepithelial space. And those keratocytes, once they become stimulated, they turn into fibroblasts and they will grow across the cornea. And how many of you have seen like a ring of, it almost looks like a Saltzman degeneration. You get a ring of subepithelial fibrotic tissue. If you see that, then it's very likely that there's a wound step there, that the cornea has been forced below the surface of the recipient. And sometimes it can be quite extensive and can cause irregular astigmatism or regular astigmatism as well. And I've had several occasions where I've had to go and peel it off. So and it peels off very nicely, just similar to a Saltzman, where you just take off the epithelium and scrape with your blade vertical to the surface, and you'll all of a sudden see a little edge, and you can take it and you can sometimes strip it off completely in one piece. And so that's probably the first thing I would do if there's extensive subepithelial scarring. It can also be induced by a suture reaction. So if you have an exuberant reaction around sutures, or if they're left in for a very long time, then you can end up with this subepithelial fibrosis, and you often see it around where a suture has been placed. So once again, for the two cardinals on the sides, turn your body a little bit, and then grasp the edge, fan the edge open, and do your suturing 90 to 95% the thickness. Once using the needle to create the tract, don't force it through, but use the curvature of the needle to create the tract. And you'll see here, actually for this one, I should have been turned like this. So you shift your whole body to the side. Or the other thing you can do that's a really easy maneuver is just take the handles of the microscope and turn it a little bit to give yourself a better angle. There's no reason to suffer. And then here's the principles of suturing. For emphasis, try and keep the needle holder parallel to the wound. You can come around all the way if you like, but this is fine as well. And always cross your hands and pull in the direction of the suture. And here you can see the suture's not under great tension, so there's no necessity to lock it. And you can, once you get into a sort of a smooth movement, there was a little bit of hesitancy. The surgeon, you could see, was going to go the other way and then realized that he had to go this way. And it goes much, if it looks smooth and if it's easy, then you're probably doing it the right way. If you're having to do a maneuver where you have to go around the suture, do you know what I mean by that? Is that clear? If you're doing a maneuver where you have to go around the suture to grasp it, then just stop for a minute and think, am I doing this the most efficient way? And try not to grasp the needle. Let me see if I've got something flat to show you. Okay, pretend this is the needle. Don't grasp it like this. Grasp the needle like this when you're pulling it through. If you do it like this, you're going to bend it or dull it. You're going to dull it most likely. So grasp it like this. And you can notice the hesitancy there, because the rule that I told you about trying to keep your needle holder parallel to the wound or perpendicular to your suture was broached. So it then became an unnatural maneuver. and try to grasp your suture long enough so that you have enough to do your 3-1-1, and you don't have to re-grip. You're trying to make your maneuvers as efficient as possible, and try and not waste your time. And you know, it should take you, well, we could time this. It should take you no more than about, I think, 60 seconds per suture. So really, you know, with a 16 bite interrupted graft, it shouldn't take you more than 15-20 minutes to do it once you get good at it. And your goal is to make all your sutures appear as if they've been done by a machine. So they're all the same length, and usually it's about, what I prefer is about 1/3 to 2/3. In other words, try and take your suture bites closer to the edge of the donor, because it's very unusual for the suture to pull through on the donor side. If it's going to erode or pull through, it's usually on the recipient side, and it's usually because the suture, you're suturing into previously infected bed, or maybe it's an infected ulcer. That's where your sutures are going to pull through.
Do you mean like cheese wire?
Cheese wire, yeah. If they're going to pull through, they may not. But if, let's say, you're doing a graft in a acute hot eye, it's not, unless the corneal tissue starts to rot, gets infected as well, or starts to melt, it's unlikely to pull through on the donor side. If it's going to pull through, you see there's a little bit of a internal tag, maybe from the previous transplant. And just like I said, I have this unstoppable urge to tinker when I'm assisting. One, two, and the other thing is that try and keep the tip of your, when you're putting the 3 throws on, try and have your needle holder end up around here, because if you're too close to the suture, the suture ends will fall off the needle holder, and then you're going to have to re-throw it again, or re-loop it again. And as you do your 3 throws, pull with your left hand to the left-hand side, and that will pull it up the needle holder. I think a lot of people, when they start out, find that it's so much more difficult to tie with the needle holder. But if you follow those principles, you'll find that it's as easy, if not easier, than using tying forceps. I find it's easier because you've got so much more surface area to grasp the suture with the needle holder. And it's, of course, more efficient, because if you're changing to a curved tire every time, you have to hand the needle holder. If you've got a good nurse, then it's not a big deal. You know, she hands you the forceps, you tie, and then you ask for the needle holder again. But you know, these instruments are built for for these functions. This makes an excellent tying forceps. Let's go on to the
And you
next
also
slide.
have like the special needle driver that's thinner, so that also makes it easier. Because sometimes if they're too thick, especially when you have like a short nylon, then it's like harder, but yours is very thin, so it's also easier.
Yeah, but it's thicker than the Katina one. And I prefer it for that reason. But you're quite right. It's the jaws are nice and smooth, and they're created in such a way to prevent the suture from getting stuck. Sometimes it'll fall into the into the joint and become incarcerated, but generally it will just slide down the jaws of the forceps. And so notice, not going to lift up on the tissue too much. You want to roll the edge away from you and try and make the needle enter the tissue vertically. And you see that, I would say that this is not perfect technique. The reason being is that I like to pass my needle right underneath the forceps because that's where the tissue is securely held. And the surgeon here has moved a little bit. I think this is Tanguy, because Tanguy is left-handed, if I'm not mistaken. And Tanguy's, he's excellent. We're nitpicking here. You have to understand. I'm really going for the details so that you can learn proper technique. But I think it's better to hold the tissue, and they're called tissue forceps because they're meant for grasping the tissue. The general surgeon taught me that until the needle passes the tissue, don't let go with your tissue forceps. So until the tip of the needle is on the outside. And I don't think you need to do that little counter pressure maneuver. And you can see Tanguy picked up the needle nicely there. And the other way of picking up the needle is that while it's in the tissue, grasp it ready for your next throw. That's if you're doing a running, sorry. In an interrupted situation, obviously, you wouldn't want to be holding onto your needle holder at that point. And he's grasped the suture in the correct way. And he just lost a point because he had to re-grip the suture end. I don't actually have a point system, but maybe we should develop one for a perfect suture, and everything that you do that's not perfect means you end up losing a point. If you get down to 0, Bill Dixon used to say that if you cut his suture, you have to buy him a bottle of wine. But I haven't instituted that rule.
Should be a whiskey shot per error.
Pardon?
Should be a
whiskey shot? Oh yeah, okay.
Per error.
Yeah, but good whiskey.
Oh no.
So do you want to watch him do the other 8 sutures? We can talk, actually what we'll talk about is burring the sutures. Here I'm fiddling once again, just putting in a little bit of BSS to keep the chamber deep, and this eye is behaving very, very, very nicely, which is great. There, he made a mistake. Did you notice that he didn't cross his hands back the other way? So
it's not square enough.
The last throw was not square. It was a granny knot. And the problem with granny knots is that they can slip. And so sometimes you'll notice when you try and bury the suture that the suture comes undone, because all you've done is you've sort of wrapped it around it. You've got one end that's sticking up, then you've got 3 wraps around it like this, and then when you pull it, it just slides off the loops. Let's see, I'll use my cord here. So, you know, if it's a granny knot, it's going to be like this, and then it's just going to like that. And what you want is a square knot, right over left, left over right. Wasn't that the way they used to teach you in Boy Scouts? And that's a square knot. That's what it should look like. And that knot is not going to is not going to slide, where if we do it the other way, see, how do you do it the other way now? I guess like this. That's a granny knot. See how instead of the ends lying down nice and flat, they also call it a square knot, I think, the other, the surgeon's knot. So you get this sort of like that. If you're lucky, it's not going to slip, but sometimes it will. But it's not as, it's a bulkier knot. You see, you do a square knot and it's nice and flat. Even if like with this, I put 2 throws or 3 throws, and then I've squared it off. You see how that stays nice and flat? So when you go to bury the suture, it's going to be narrow and it's going to go nicely into the opening. So burying, so let's talk a little bit about burying the sutures. If there's a little bit of helon on the surface, it helps. And also, if you bury them shortly after the knot has been tied, it's easier. So if you wait until the end, and when you've got all 16 sutures, then the opening that was created by the needle will actually constrict a little bit, and it may actually be harder for you to bury the suture. When you tie your sutures, your first one is just to lay it down, the 3 throws, nice and flat, and oppose the tissue. Your second one, and I learned this from a resident that was a year ahead of me, Mel Rote, who's excellent guy. He's in, he lives outside of Pittsburgh or Philadelphia, one of the two. So what he taught me to do is on the second throw, you pull it, that's just to lock your knot, but it's not to cinch it down. It's your third knot that you cinch down to try and constrict the knot and make it as small as possible. And that makes
but
it
the tension, you decide the tension on the second one?
That's right. Decide the tension on the second one. The third one is the lock-in knot. And because if you pull it tight on the second one, that triple throw, let's just go back to my Apple device here. 1, 2, 3. And then when you make your nice square knot, if you make it too tight, look what happens. You end up with a Gordian knot, right? Like you end up with this big bulky thing. Whereas if you he's locking it there, which is probably unnecessary in a graft like this, where there's really little tension on the suture. It's important to know how to lock it. We'll talk about that as well in a minute, what I think is the best way to lock it, or at least the way I do it. And yeah, so getting back to the second, if that second throw is too tight, then it scrunches up that three throw part of the knot into a big glob. And that makes it harder to bury the knot. And even more important, it makes it harder to take it out. So the second one, as Gisela so elegantly put it, it secures your tension. And the third one is a locking knot, right? Because then it's just 1-1. And so that little bit on top is going to be nice and compact. So let's talk a bit about burying the sutures. I find it's usually easier to bury them on the scleral side. Now, it looks like we lost our video. Let's go back.
And also, for when you say you're going to explain how secure it, like lock it when you have the 3 throws. I guess in the first 4 sutures, you might need that more because it's less stable. But once you have the 4 cardinals, then that's less necessary.
Yeah, except the first one, usually you don't have to lock it because there's absolutely no tension on it. It's totally free floating. So if you lock your first one, it's going to end up being very tight. And then it may give you more difficulty. It might sink the edge and make it difficulty for you to grasp. So we're going to talk, we're going to talk about sinking the edge and how to retrieve the tissue if it is sunk. And we're going to talk about locking the knot as well. What a good way to, the proper way to lock it, and at least in my opinion. But let's finish up with burying the knots. It's usually easier on the recipient side, and that's for 2 reasons. Often the tissue, like here, look, it's kind of scarred and vascularized, and that tissue is not normal in terms.
Showing anything, Prof? Because I can only see the your media library list. Are you on a video?
I was just a second. I am, but it's not coming up here. Sorry, new share. Oh, it came up on QuickTime, and that's why.
Yeah, got it.
Okay. So if you bury it on the scleral side, you know, especially if you're going through a scar or vascularized tissue, you'll find it's really much easier than like a keratoconus or a Fuchs dystrophy. Not that we do PKs and Fuchs anymore, but let's say a granular dystrophy or something like that. Because the normal structure of the collagen, I believe, has been interrupted. So what you want to do is hold your needle holder. Oh, actually, I have a small pair of forceps here. You have your forceps, and you want to hold them so that you're coming to, can you see this, or is it too small? So that you're coming down on the suture like this. If this is the suture here, you're coming down on it like this.
Rob, can you lift it up right into the screen? Thank you.
Yeah, thanks. What I mean by that is try not to go like this underneath. That has a tendency to break your sutures. You want to come vertical to the surface with your forceps and then push them like that. And what that'll do though is, look here, you can actually see it. See which way the arrowhead is pointed? It's pointed this way. And when we take out sutures, which way do we like to take out sutures? Which way? Tanya, go ahead. Which way do we pull them out?
So I tend to, well, depends which surgeon I'm working with, because your arrowheads are actually facing different ways.
Mm.
So
well, this is wrong, what I'm trying to point out.
Yeah. Because it's digging in.
Yeah, this would, usually you pull out the suture under optimal conditions in the direction that the arrow is pointing, but we don't want to pull it out on the corneal side, because in theory it could avulse your wound. If it's well healed, it's unlikely to happen, but it can occur. So what I like to do is to pull the suture, sort of push it this way, so because it's easier to do it on this, to get it to go on the scleral side, and then reverse it, so that you reverse the arrowhead so that it's pointed. I've got an unstable internet connection. Okay, so you get the arrow pointing towards the scleral side. Does that make sense to everyone?
So
Yes,
basically,
and you remove them from the recipient side.
yeah.
You remove them from the recipient side, and when you remove them, you know, you can use a Van Ness scissors, but it's not necessary. You can use a 15-degree blade, but that's expensive. You know, they're about 20 bucks a piece, so you really don't need it. The best needle remover or needle cutter is a 25 gauge needle. It's the perfect combination of rigidity and sharpness. I mean, they're super, super sharp, and yet they're not so flexible. You can do it with a 30 and it's not a problem, but when you do it with a 30, you'll hear it go ping, ping, ping. Whereas with the 25 gauge needle, it's you just have to actually insert it. You know, if this is the loop of your suture, you'll just insert the needle here and just go, and usually it'll cut it. When you're taking out the sutures, what I like to do is to cut it right here with the needle, and then rotate the needle 90 degrees so that it's the flat part, right? So you've gone, actually, sorry, you can either go 90 degrees like this with to the suture and go underneath it and go flick, or you can go with the flat part of the needle, just go underneath it and then pull towards the center. The idea being is that you want to cut the suture right as close to the corneal surface as possible. Because if it gets stuck in the tissue, you'll probably have dragged it a little bit, and that suture end will get stuck in the tissue, and it won't cause a problem in terms of irritation or a nidus for infection. So you want to just nick it here, and then with the flat part of the needle, go to this end here and flick it out. We should try and make a video of this in the clinic one time, of the proper way to take out sutures. That would be useful now that we've got that beautiful setup that we're so lucky to have. So you'll flick it out, and now you're going to have a little mouse tail hanging over here. And now you've got a nice big area. I just want to stop this video for a sec if I can. That is the locking part. Then now you've got a nice long tail to grab onto. And if you grasp it and just give it a good flick, it'll come out. And I feel that we should use sterile forceps, because tears are a contaminated fluid. They're filled with good stuff, but they're also filled with bad stuff. And if it were me, I wouldn't want someone coming near me with an unsterile pair of forceps. Now, what kind of forceps are the best ones? I don't think the Tennants, the ones that we use in the OR, are the best for suture removal. The best are those jeweler forceps that I buy from Stevens Instruments in the US. And they're only about 20 bucks a pair. So every year when I go to the academy, or if I go to the ASCRS, I'll pick up about 10. And because they get dinged, they're not fantastic in terms of quality, but also if they break, it's not the end of the world. It's $20, you know. You buy a pair of Tennants and they're $150 US, you know, and they fall, or they get, you know, how they sometimes get like this, and then they're useless. Whereas the jeweler's forceps they look like this. These are like a small jeweler's here. And there used to be a company that I would take them to them, and they would make the edges rough a little bit. Actually, you know where there was a company that Eagle that makes the punctal occlusion devices. They also had a forceps for inserting the devices, and it had a little carbureted tip to them, so they were rough, and that's why I I liked them so much. But I think I wasn't able to get them anymore. But there was a company I used to, so I'd go from one booth from Stevens, and I'd buy 10 pairs, and I'd take them to the other booth, and they would roughen the edge so that they grasp the suture. And you don't want something that's excessively pointed. You don't need that. For one thing, they're too delicate, so they end up, have you ever seen the ones that they look like this? It's like a claw, and you're trying to grasp the suture, and it's like, oh boy. And then you go get another pair. By the fifth pair, you finally get a pair that works. And that's if you rely. Pardon? Go ahead, Tanya.
I don't know how much the containers are, but one of the clinics has little separate containers, but they also put the soft spongy caps. And I just think the rate of damage is significantly less. So just to save you a bit of money, like, I don't know if the containers are like actually hundreds of dollars and then it doesn't actually work out to be cheaper, but I do think it just preserves your instruments a bit longer.
Actually, that's a great idea. Actually, we could even just get...
you can just do it with the...
sorry,
I don't know how to say.
You can take tubing. You could take
exactly.
Exactly.
silicone
I don't know how to say it. Yeah.
Butterfly cannula tubing.
Yeah, right. You know what I'm gonna do? I think Jen usually does it, or does she dump that onto Maria? I can't remember.
I don't know, but it's just that.
Well, right now Patrick is helping me with that because we had lots of instruments we've been using, and he's going in today. So actually,
I just noticed it because when I was cleaning out with Patrick over Christmas, the amount of broken instruments we had was huge. Like, it's so much wasted money there.
Yeah, it is a shame. Yeah, the suture removal forceps are the only ones that, if I'm going to buy something, I'll usually buy stores. I think stores are by far and away the best instruments that are available. I've tried, like, in my opinion, forget the South Asian created ones, unless you're just using them for practice and you're never gonna, you don't expect them to last. But if you're gonna put together a pterygium tray, you don't need a curved Colibri 1-2 to do a pterygium. Those ones are $500. You can do it with a Bond 0.12, and those ones are about 150. Both of them made by stores. So if I'm stocking a pterygium tray, that's what I'll do. I think also these needle holders are more robust. They're going to last you longer. They're not going to get little dings in the metal, and the jaws won't meet properly and stuff like that. These are expensive. They're about $500 a pair, but beautifully made instrument. So did we finish about burring the sutures? Yeah, a couple other points. Put a little Helon on the surface. Put a little tension in the eye, like if the eye's too soft. Hello. Are you going to come and see our butterflies this year?
We are waiting to be invited.
Okay, well, we got to wait till they won't be for a couple months because the weed hasn't started to grow yet. But hopefully we'll get some more butterflies this year. Okay, so yeah, fill the eye with a little bit of BSS, and then grasp the ring. That's the nice thing about having the ring. If you need to, or if you've got the Goldman ring, the eye's more secured, and I think that's why you'll find it's easier to bury the suture if you do sew a ring on. Plus, you don't have to cause all these subconjunctival hemorrhages when you grasp the eye. So don't grasp here. If you do need to grasp, if you stabilize the wound by grasping with your 0.12 forceps, say here, while you're trying to bury this suture, you'll find that it goes much easier. So a little bit of pressure, a little bit of helon, grasping the eye so it doesn't move, and remember to reverse the knot. So drag it this way and then pull it back this way, and try under optimal circumstances to leave the knot just under Bowman's layer. And that's being kind to your next fellow, who will likely be the one, or kind to me, because even sometimes I still take out sutures. And be kind to the next person that has to take out the sutures. All right.
Can you
yeah.
tell us about when you do your viscoelastic / BSS exchange? Like, do you do it after the first 8, or do you do it after at the final bit? And I noticed that some people had originally taught me before I came to the fellowship to depress the lip of the wound so your viscoelastic can escape, which means you're actually pushing fluid in. But I did that with you once, and then we had an iris prolapse, and you taught me to actually aspirate first and then put in your BSS.
Right. I think, well, in a pseudophakic eye, I think the easiest way to do it is to go in with your cannula, first go vertical and then slide it horizontal, and put a little posterior pressure on the center of the lens, and then aspirate there. So you'll aspirate a little bit, come out, and then I like to squirt it onto the conjunctiva so that you can verify that you actually got some BSS. Then inflate again with BSS and repeat that, and repeat it a few times, and that should get it. That's why it's better to use helon than viscoat, because helon's cohesive and it'll be much easier to aspirate it. And you're quite correct. If you do inject, you're either going to cause the iris to prolapse here, or it'll prolapse, you know, at the spot that's weakest. So you'll see the wound open up, and you'll see a bloop of helon come out. And if you're not careful, you may miss that you've created a synechia there. So, and if it's a phakic patient, like a keratoconus, then I'll often put the cannula sort of parallel to the wound or perpendicular to the suture, if this is a suture. So I'll put it underneath and aspirate gently over top of the iris, squirt out the helon, and then refill with BSS, and do that a few times. But you're quite correct. I don't like the forceful ejection method. For,
do you do it right at the end only? Because there's some talk about whether you have BSS and whether that gives you a different tension to when you're putting in the second set of sutures, or do you do it right at the very end? Or do you makes a difference?
I do it usually when there's 1 or 2 sutures left, so that you've got a bit of an opening. But you can do it at the end. Even it doesn't matter all that much, and I don't think it matters if you got helon or BSS. It's more the appropriate tension. I like the viscoelastic in the eye for as long as possible, because it does keep the chamber deep and pushes the iris back, and keeps it from getting stuck in the wound. So, you know, usually if I've got a couple suture openings, and especially if I'm assisting and I've got nothing else to do, then I'll be fidgeting once again. Okay, let's talk a little bit about locking the suture. So the correct way to do it is, you know, you'll do 3 throws. Let me just get this right. 3 throws, you'll grasp it, and then you'll pull it this way. And then keeping the suture parallel to the surface, you'll sort of drag it along the surface in a counterclockwise. For me, I usually do it counterclockwise like this. And while you're keeping tension on it, if you try and do that and the suture's not under tension, it'll just untie. So you've got your knot like this, and then you'll go like that. See if I can demonstrate it with my Apple product here. Okay, so you've got a loop like this now, right? Because this, is that right? Let me just see. No, I had it the other way is correct. Yeah, that's right. Okay, so you've got your loop like this. It's actually like this, and then you'll take the end with the needle on it, and you'll pull it around like that. Now you can see how it's locked. See, if I lift up like this, or if I don't have it under tension, then sometimes it'll just get looser. This is sticky enough that that's not happening. But you'll see that as I go this way, see what happens to the knot. Whoops. There. So that's how it locks. And that's the most elegant way to do it, I think. I learned that from Marguerite MacDonald. She is an excellent technical surgeon, and she taught us about the burring the knot things, and about how to lock the suture efficiently. Because you see people when they try and lock the suture when they haven't had much experience with it, and it's a struggle at first, and you do it 3-4 times until you finally get it right. But if you do that, keep it under tension and just go around the clock hours with the suture parallel to the surface. Does that make sense?
Yes.
Yeah, makes sense, and solve some frustrating time in the OR. Totally makes sense, I'm saying.
Yeah, okay, great. All right, so I think we've sort of exhausted this video, but what I thought we could do is look at this one, which has transscleral suture, because this is a situation that you'll often come up against. Can you see that? Or I got to do a new share, right? Okay, so this is the Moria tree vine, and we've just marked on there. Oh, I think I even know who this patient is. He's a guy that had a graft for keratoconus, and then he got poked in the eye, and we had to suture him up, and you can see there's some iris damage plus the sutures from the repair. The graft became cloudy, so we decided to repeat it. And here I'm ignoring the old graft because the old one was either decentered, or with the keratoconus, it's possible that some of that thin keratoconic tissue has continued to stretch. So let's talk a little bit about the Moria tree vine. We actually, Garth Wilbanks, who was my fellow in 1994, I think 93, really nice guy. He had tremendous academic potential. He did this great study together with Rob Inman, who's one of our rheumatologists, and they did a uveitis study. They created an experimental model of uveitis, and he had the really smart guy. He's unfortunately, his timing was bad. He couldn't get an academic job anywhere, and he ended up. He's got a great position. He practices in rural Maine, which is just beautiful country from what I understand. You know, it's probably one of the most untouched wildernesses in the United States. Very low population in Bangor, Maine, and has developed a terrific practice there. I was just always kind of hoping that he would have got a job in Boston or something like that to continue his academic bent. And I never see him at meetings. I'm in touch with him once in a while. You'll see his name on Keranet sometimes, and they're usually very intelligent. They're always intelligent comments. I've never heard him say anything that I thought was off the wall. Or anything
What's
like
his
that.
name again? Sorry, boss. What's his name?
Garth Wilbanks. And he's a Southerner. He's a Southern gentleman from Georgia. I want to mention one thing about these forceps, the Colibris as well as the Bond. This area here is what do you call that? Anybody?
It's part of the shaft, no? It's the
Time.
plate.
It's a tine platform. So Bond forceps and the long Colibris and the short Colibris all have a tine platform. So that's why you don't need to switch back and forth between forceps, provided this hasn't been ruined by someone in CSR. But you should be able to tie quite nicely with the tying forceps. And then at the tips, you've got the teeth. Right? So it's a tissue forceps with teeth, but it's also got a tying platform. So let's get back to the case at hand. This was done at the Western. You can see, for one thing, because we used the Moria tree fine. Number two, the video, our old video, tended to give you this large vignette around the outside. Yeah, the Moria tree fine tends to, well, not tends to, it gives you suction in the perilimbal area. And that's what reminded me about Garth Wilbanks, is that Garth did a study comparing the results of Hesburgh Barren to Moria. And I think we found less astigmatism. This is before we even had a topographer. But he found less astigmatism, if I'm not mistaken, using the Moria tree fine. Theory being that with the Moria, you get a more vertical cut because the cornea isn't being distorted or pulled into the suction chamber like happens with the Hesburgh Barren tree fine, because it grasps beyond the limbus. So that's one advantage of it. So that the blade is it's still never, I mean, really, if you wanted to have a perfect cut, it would actually cut like this, wouldn't it? If we're taking a straight blade and cutting on a curved surface, regardless of whether you're using suction on the cornea or suction on the limbus, that cut is not going to be parallel to the surface. And then what do? We take the donor, we flip it over, and we punch it with a different methodology, which gives you a great mismatch in the cuts, and that's why we have to oversize a little bit. And now you can overcome one of those problems by mounting the cornea on an artificial chamber. And I did that for quite a while. I think we should go back to doing it as well. So you mounted.
That's also when you do the femto cut. That's also the way what you're doing, right?
You don't like, or?
No, I mean, like when you're preparing the graft with the femto,
yeah.
You're also doing it onto the artificial chambers. So probably that also improves the matching of the two.
Yeah, you're going to have matching, but with the, I hadn't thought about it till you mentioned it, but with the femto, we should have the ability to actually cut vertical to the surface, because we're cutting like this. There's no reason we have to. We can put a little bit of an angle on it, We just have to calculate what the proper angle would be. But you're quite right. Since we're cutting it with the femto, it's ending up to be at least a match. Although we're doing, usually with the femto, we're doing a jigsaw puzzle kind of cut, you know, a mushroom or a top hat, or I don't like zigzags so much. But so those are some of the issues with the different tree finds. And what since I know we're going to be sewing in a lens in this case, we're going to create a Hoffman pocket. And this is one way of sewing in a lens. Believe it or not, I started sewing in lenses when I was a fellow, so it's not a really new technique. You know, I've been doing it for over 30 years, and I can only think of one or two cases where there was a problem. One where the haptic optic junction pulled apart, you know, because you know how they make those lenses is that they create the lens, the three-piece ones anyhow, and then they drill a little hole in it and they stick the Prolene haptic or the PMMA haptic into the lens. So it's not terribly well secured. I don't think they even put any glue on it, to tell you the truth. And so I've seen with the Yamini once where the haptic and optic came apart. I didn't do that one. Can't blame myself for that one. But I had it happen to one of my patients like several years later with an MA60 lens, which we don't like MA60 lenses anyhow. We're not going to use those anymore. And I also think that the three-piece lenses aren't optimal for sewing in, because when you pull the two haptics, we'll have to demonstrate it sometime. But if you take a one-piece lens and you pull it like this, it torques and twists. And the same thing with the three-piece lens. And I think the three-piece lenses aren't stable in the sulcus because they're so flexible at the end. So especially if you're open sky, the best lens is the CZ70 BD, 7mm optic, PMMA, very rigid lens, and it's got the two little doohickeys that you can use to sew them in. So for many years I used 10-0 Prolene, and I didn't have like a lot of dislocations or dissolutions of the sutures. I think you have to be careful with that suture, because if you handle it too much with a metal instrument, you're going to squish it and weaken it. But if you're careful with the suture, I don't think it's going to dissolve in your lifetime anyhow.
Do you find there's a better shelf longevity with Gore-Tex opposed to Prolene, or?
There probably is, but I switched to quite a while ago to 9-0 Prolene, and 9-0 Prolene is much more robust. Now Gore-Tex, I don't like it personally. It's like, it's dental floss, you know. It's very thick. Yeah, and it has a tendency to erode if it's not covered with sclera. And that can cause a lot of problems with erosion. The worst that happens with the Prolene is sometimes you get a little end sticking up, and that can cause some irritation. But you can go back and make a little conge flap, you know, cut a 3mm button from a piece of cornea, thin it out, and just slip it under with a little bit of glue, and you know, it's not a big deal. Or better yet, make a Hoffman pocket, or we've gone now to making a partial Hoffman pocket. This one is probably a complete Hoffman, which I did for so many years, and now that I think about it, it doesn't make sense. It's a waste of effort and a good chance to cause some bleeding, or I've perforated into the ciliary space once or twice. Doesn't usually cause a problem, but obviously not the best thing to do. So let's see how we did it here. Is that you make a vertical cut. It's not moving. Make a vertical cut just at the edge. It probably cause some bleeding. And I tend to make it a little bit longer probably than most people, because I find that then when you turn the blade over to go parallel to the sclera, if the incision isn't long enough, you won't have enough wiggle room. And you know the difference between a wiggle and a waggle? Somebody pointed it out on CareNet about a year ago. I thought it was quite brilliant. A wiggle is when you wiggle the tip like this. A waggle is when the tip stays stationary and it's the heel of the blade that's moving. So you know with this, let's see if I use a wiggle or a waggle or a combination of the two. You know, I think the waggle sometimes gives you better dissection. So you just want to make that vertical cut down about 50% depth, and just stroke it until you get to the depth that you like. So now I'm only making a partial hop, and I'll actually go a little bit more anterior and just shelve it back maybe a millimeter or so. And we'll talk about it next time, how to do that. Maybe if Giselle, if you're in the office who's in on Thursday?
Me, yes, I'm going.
Yeah, so if you look see if you can find a partial Hoffman pocket on the hard drive.
I have most of the videos from this year with me, so I can look
yeah?
it up here. Yeah.
Oh, great.
But what do you mean partial? Like just
well, not such. See how this one?
you use?
This is a regular Hoffman pocket where. And sorry for it's getting kind of jumpy out, and probably because it's coming off the hard drive, but a regular Hoffman pocket, you'll have to make it about at least 3 millimeters back, so because you're going to puncture through the pocket to the outside, whereas a partial Hoffman is just a little tiny pocket here.
Yeah, I guess you've been only doing partials this year. So right. Those are the ones I have. Yeah.
Okay, great. So maybe you'll share the screen next time. You can put it on your screen and we can show the difference. So here what I'm doing is trying to go down about 50% depth. And I'm grasping the edge of the cornea because the corneal tissue's nice and firm.
Prof, did you just do a quick DALC just to clear the view? Is that why there's a circle on the cornea?
I think it's because of the adhesive.
PK. Yeah, he had a previous PK.
Okay, it just looks like there's a step there,
Oh.
Isn't that the exact trephination? No.
Yeah, it looks like a trephination.
Because
this
he initially
is the original trephination, and this is we did a partial thickness keratotomy. I did it before sewing a ring on, or before creating I did the trephination partial thickness.
Okay.
Because I knew I was going to have to.
Okay.
Oh, because you knew that you wanted to do the pockets.
Right.
Yeah.
You can see I probably perforated here because there's aqueous flowing out, but it usually doesn't cause a problem. Now we're just.
I was going to ask about that trephine you used because I'm not so familiar with it. I'm always scared that it's heavy and it's gonna push on the eye. So should you try to hold it up, or it doesn't really
just support it? Just support it. You want to push down firmly, when you apply the suction, you get your assistant to pull on the syringe, and then you can jiggle it a little bit to make sure that the suction is advanced. So with that one, it's I don't know if I know I've got a VHS tape of care and usage of the, if I can find it. It's in a box somewhere. But you know, it comes in two pieces. There's the cone piece that holds the blade, and the blade rotates and advances. And then you've got the outer piece, which is just the passive cone part that you screw on afterwards. So you assemble it. First you put the blade on, and then hold it on the side. You'll see there's a little window that has, you should be able to see a number on it, unless it's in between the numbers or if it's too far, if it's turned all the way. And you see how I'm not even holding close to the suture end when I pass it. I was actually holding 180 degrees away from it just to stabilize the eye. So then you can use there's a little round wrench, and you click it and it goes click, 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 and it goes anywhere from, I think, 2 to 12, or you can go beyond 12, which is maximal. And it'll give you a partial thickness cut. It's totally dependent upon how good your suction is. And if there's a lot of chemosis, then you may not get an accurate depth. That's why eventually I got them at the Western to get us the those one-piece Moria ones. I think they're better for Dalk than this big Moria one. Probably if we did them all under general anesthetic, the Moria would be fine. But so with the silk, it's really 2-1 should, if it's a square knot, should hold. And since we're not going to leave these in, we'll just go 2-1-1, and we're using that fine needle holder for some reason.
Can we do the trephination with the Aspen Baron after putting this ring, or it always has to be like first doing the trephination?
No, you can do it. Yeah, you can with the Hesburgh Baron. Yeah, you can do it afterwards, because we're not worried about access. It's at maximum diameter. It's only 11 or 12 millimeters, I think. Whereas the Moria is probably 14. It's about exactly if you've sewn it on perfectly, then you'll be fine. But if it's a little bit off, or if you get a subconch hemorrhage, then you're going to have trouble with the suction on the Moria. So it's probably better to do the trephination, only go partial thickness, and then sew the ring on. Or if you do happen to penetrate, just put a couple sutures in where you penetrated, and fill the eye up, make it a little bit firm so you can sew the ring on. All right, so you can see this ring here is open on the sides, and that's to facilitate sewing the ring in a horizontal position, or sewing the lens in a horizontal position. Okay, so maybe we'll pick up from there on Thursday.